I would like to thank everyone for coming out this afternoon and just ask the last few people to take their seat. We are fantastically lucky to have leaders in the fields of dermatology, surgical oncology, and medical oncology here to share with us their wisdom on melanoma this afternoon. Before we get into the program, however, I want to invite Jerry Tatar up for a few words.
Thank you, Dr. Kyler. Well, thank you all for coming. I know you're all very busy people, and we are privileged that you took time out of your day to come here and learn something about the newest things in melanoma. And as Dr. Kyler indicated, we have 3 of the world-class researchers in this area to discuss this with you. In addition to that, I've learned that there's a new system, so let me do a couple things. That's me. And this is the subject. And let's see, annotation clear? And I can get rid of it. So I learned a lot already. So, listen, we're very thankful that you're here. And out at lunch, a couple of people were kind enough to ask why the Tatar family does this. So let me take a couple minutes just to explain that. This is all very personal to me. Back in 2007, my wife Lorelei, she passed away from melanoma, actually, and she passed away on her birthday and on Thanksgiving Day of 2007. And she started fighting that battle about a year before that. And as the support system for my wife, I learned a lot during that period of time. And mostly it was a lot of frustration because particularly melanoma, back in 2007, once it got into the system, microcells, and they start flourishing, there wasn't a lot that you could do about it. And I learned that, but I didn't believe it. So for many, many nights, I used to sit in front of a computer trying to find something, and never could, really. And people were always very kind, and they would come to me and say, well, you must take Lori to Anderson down in Houston, or Hutchinson in Seattle, or someplace in Germany. And the truth is, I could barely get Lori down 2 miles away to go to the chemo center. It was pretty rough at the end. And so, that's the way things happen. But it always bothered me that as a support person or as the patient, you're never quite sure that you know exactly what the newest stuff is, the best stuff is, et cetera. So that kind of troubled me. And then about 2 years later, I met Dr. Kyler, and I met his associate, Dr. Einstein. And we had lunch one day, and we got talking about this. And we came up with this idea of having an annual symposium where we would indeed bring in the best specialists in the world to discuss a particular topic. And in the first year, we did. I always asked them, when could we do melanoma? But in the first year, there still wasn't much about melanoma. But first year, we did the breakthroughs in metastasized cancers. The second year, we did breast cancer. The third year, we did lung cancer and customized ways of treating lung cancer. Last year, we did prostate cancer. And finally, when we had our annual meeting to discuss what the topic is going to be, I was so excited that Dr. Kyler said, I think it's time, and we can do melanoma. So that's full circle. We're here, and we have a place to have dinner with the 3 doctors last night. And they'll all lose me, after 20 minutes, I'm sure. But I'll try to hang in there with them. But I now know there are a lot of new things available to melanoma patients. And my whole view for doing this, the family's view for doing this, is that we want the people in Dayton to have the best available knowledge that's out there. And this is our little part in trying to make that happen in the community in the region of Dayton. So again, I thank you for being here. Please sit back, get your pencils on and take a few notes here and there. But I know all the slides are available, because there is a thing called a thumb drive out there, which I didn't know what it was till somebody else described it to me. So all the slides, I think, are on that thumb drive. So you don't have to worry too much about that. And so besides learning some technology today, I'm looking forward to learning something about melanoma. Thank you.
Thank you, Jerry. As I think almost everyone in the audience knows, this is a very unique symposium. It's CME that is provided free of charge with a lunch, and that's really Jerry's doing. And it's the 5th year that we've been able to do this thanks to the Tatar family's philanthropy. So I want to give them a thank you too. So this year's topics, trends and updates in melanoma. Our first speaker is Dr. Caroline Kim. She co-founded and chairs the Pigmented Lesion Subcommittee and the Melanoma Prevention Working Group of ECOG-SWOG. She chairs the American Academy of Dermatology's Academic Dermatology Leadership Program. She completed her undergraduate and graduate education at Harvard, where she earned a Howard Hughes Medical Institute Research Fellowship. And she completed her residency education at Harvard as well, and received a Women's Dermatologic Society Award to study pigmented lesions at, of all places, Yale. So currently she is the director of the Pigmented Lesion Clinic and associate director of the Cutaneous Oncology program at Beth Israel Deaconess, and is assistant professor of dermatology at Harvard Medical School. She is active as a principal investigator and co-investigator in research studies involving which word should I stumble on? Involving melanoma epidemiology and diagnosis and management of atypical nevi. She will be talking about screening and diagnosis. Dr. Kim.
Thank you so much, Dr. Kyler and Mr. Tatar, for inviting me to be here today. It's such a meaningful symposium, and we were talking about last night how the timing of it is just really perfect, because this field of melanoma is really evolving and changing very quickly, as you'll hear today. So it's a real pleasure to be here today to talk to you all about melanoma screening and diagnosis. And over the next 45 minutes or so, I wanted to give you updates in both of these fields and also talk about some of the current challenges that we are still facing. I just want to disclose I do have some industry relationships. But as an overview, really, I'm just going to jump in. We're going to spend the first part of the talk really diving into melanoma screening. And then we're going to spend the majority of the rest of the time talking about melanoma diagnosis, what we're doing to help with this diagnosis in our clinics, and what's coming up the pike as well. So as we all know, the incidence of melanoma is on the rise. Currently, it's estimated that about 1 in 50 individuals in the United States have a diagnosis of melanoma, and it touches everybody. You might have a loved one that had melanoma, you might have a neighbor. Everybody seems to know somebody who's had melanoma. So this is a very important disease. And over the years, unlike other cancers, the mortality rate has continued to climb. So this is a very important problem. And importantly, as you can see, the survival graph stage really matters. So early detection of melanoma extremely influences survival. And that's really where our focus in dermatology is, because we're trying to get out there and educate and screen to try to diagnose this disease at the earliest stage possible so we can give people the best prognosis. So let's start with the question of who should be screened for melanoma. When we think about screening, you have to think about the risk factors. So who gets melanoma? Well, there's been an explosion of a lot of new genetic information, and there are definitely genes that we know are involved in melanoma. A small percentage of genes are involved in familial melanoma, where it's hereditary, but actually a large portion of patients have no family history of melanoma. So there are other mutations that happen as well. We also know that people with fair skin, people who have red hair actually as well, people who have had extensive UV damage, whether it's by the sun or tanning salons, people with increased numbers of moles, greater than 50 moles on their skin, people with atypical moles, which I'll show you pictures of, people who've had any history of immunosuppression, and of course people who've had a family history of melanoma are at increased risk. But when you look at this list, how do we pick out those patients in your clinics to send to dermatology to get screened? Are we doing a good enough job at identifying these people? Well, what I've seen in my high-risk clinic is that I think we're doing a pretty good job at detecting some of these folks, the people who have increased numbers of moles and the people who have atypical moles. And I think it's because it's readily identifiable. When you see somebody who walks into your clinic, you'll know right away, as soon as you get them undressed, that they have a lot of moles or atypical ones. So this is a typical patient that's sent to me because they've been identified as being high risk for melanoma. There are other moles, though, that do look a little more ominous. They may not be perfectly circular, perfectly symmetric, as you can see in the bottom picture there, and these can be very worrisome. Now, there are some patients who are covered with atypical moles where every single mole looks like it potentially could be melanoma, and those are the scary patients, right? The patients that you worry you don't want to miss the melanoma on them. And those are the typical patients that get sent to our pigmented lesion clinic, the people who are covered with the unusual looking moles because they are higher risk. And just to tell you a little bit about atypical nevi, it accounts for about 2 to 8% of the Caucasian populations. And pathogenesis, we believe that there is an environmental exposure component to it, probably some UV damage, but a lot of it is genetic, and we definitely know that there are genetic reasons why people make atypical moles. The significance of identifying these patients, though, is that we know from studies that patients with atypical moles have an increased risk of making melanoma. Now, if in the general population that risk is about 0.7%, did that work? Okay. With atypical moles, that increases 2 to 12 times. And if you have atypical mole syndrome, where you might have more than 100 moles, one of them being greater than 8 millimeters in diameter, the 10-year cumulative risk for developing melanoma is actually 10.7% versus 0.62%. So that is definitely a higher risk. What's interesting about these patients, though, is that their individual moles, there's no information, there's no data to suggest that these nevi, these moles, are on a progression to melanoma. So you imagine someone's covered with 100 of these atypical moles. We can't say to them that these 100 moles are all going to turn to melanoma in 20 years. And that's part of the challenge because people come in and they're really worried and they want them all off. But rather, they're a marker for the patient who is at higher risk for making melanoma. And we know that 75% of melanomas arise on normal skin. So you can have 100 moles, but your odds of having melanoma are almost higher that you're going to have it on a piece of normal skin that you have, not associated with the moles that you've been obsessing and looking at. So it's an interesting finding. So what do we do with these patients? We monitor them very carefully. And I try to emphasize to my patients, the goal is not to remove all their moles. And there actually have been case reports of patients having all their moles removed, but still developing melanoma. So our goal, again, it's not to demole them, but it's to follow them carefully to be very good at identifying what a melanoma would look like on that patient. But what's so interesting is that here in our clinic, we're getting sent a lot of moly patients, a lot of people with atypical moles. But, I take care of advanced stage melanoma patients as well. And what we observed in our clinics is that a lot of the patients with advanced disease had no moles. So, and here I was taking care of a lot of these moly patients who ended up having kind of less severe types of melanoma. So we actually wanted to study this, and this was just presented a couple weeks ago at our Academy of Dermatology summer meeting. We conducted a retrospective chart review of 281 melanoma patients in our program at Beth Israel. 89 patients had more than 50 moles, 192 with fewer than 50 moles. And compared to the moly patients, the patients with fewer moles were diagnosed at an older age, 51 versus 41 years. They had thicker tumors, and thickness really correlates with outcome as well. 1.8 millimeters versus 1.3 millimeters thick. Their tumors had more dividing cells. Higher average mitotic rate was 4 mites per millimeter square versus 2, and the tumors were more likely to be nodular, so an aggressive variant. So in all, the patients with fewer moles really indeed did seem to have more aggressive tumors, which was interesting because, obviously when we look back at our risk factor list, and we're pretty good at identifying those patients who are moly and have atypical moles, what about everybody else? Are we doing a good enough job in identifying and sending everybody with all these other risk factors to get their skin screened? Well, I can tell you that we could be doing better because I talk to my patients in our advanced melanoma clinics, and time again, I hear from our patients, doc, I didn't even know that I should be screened. I didn't know I was at risk. I don't have any moles. Why should I go be screened for melanoma? Or they might not have heard of melanoma. So there is this really pressing need to improve our education to reach really, truly everybody who needs to be screened. And strikingly, I want to point out that the United States Preventative Services Task Force made a statement in 2009 concluding that the current evidence was insufficient to assess the balance of benefits and harms using a whole body skin examination. So in short, they could not recommend any guidelines for skin cancer screening. So to this day, there are no real firm guidelines in place. So who we end up seeing in the clinic to get screened for melanoma really depends on the primary care physicians or what other care providers end up sending their patients to dermatology. So this is an important point. The onus is on us to create this evidence and to do research to prove that we need to get better skin cancer screening methods out there. Now, one new update is that in 2012, a German study was published. Does skin cancer screening save lives? So this was good news for us. Over 1 year, basically in Germany, in a city, in an area, Schleswig-Holstein, they actually performed a population-based skin cancer screening project where they screened over 360,000 people over the age of 20, and they followed trends in mortality in the following years. And very interestingly, they actually were able to show that after the screening, they showed compared to the pre-screening data, melanoma mortality declined by 47% for men and 49% for women. So for the first time it was published that melanoma mortality went down after population-wide screening. So we hope that this is the first of many studies to come out. There is an ongoing effort in Pittsburgh actually trying to recreate the population-wide screening to study that as well. And we also need to understand risk factors better so we can fine-tune the populations we need to target, because we could, again, be doing a better job at targeting people to educate and screen them for this disease. So let's segue to melanoma diagnosis now. And before we talk about diagnosis, I wanted to show this slide to emphasize that melanomas come in different flavors and different subtypes, right? They don't all look the same. The majority of melanomas are the superficial spreading type, and then there are other subtypes. I'm going to show you pictures of all of them just to remind you that they don't all look the same. So this is probably what you had in your mind in terms of what melanoma looked like, and this is what's in the textbooks, this is what people know about. Usually I'd venture to guess that most people, if you had a patient in your office, would recognize this as something very unusual and would need to come out. So this actually makes up about 70-75% of all melanomas. On the men, it happens more in the trunk, on women, on the legs. You see the color variation, irregular borders. This just looks very unusual and atypical. But there are other variants. So nodular melanoma, which actually is the version that grows downward, and it's very, and considered much more aggressive, that encompasses about 15 to 30% of melanomas. These can look symmetric. They can look one-colored. So they don't look like the little pamphlets that you get necessarily, at the grocery store for looking for skin cancer. They look different. So everybody needs to know that. Lentigo maligna is another type. This is about 15% of melanomas that occur more in chronically sun-damaged areas. Face tends to be a very high risk area. And the average age of diagnosis is usually in the 7th decade of life. Acrolentiginous melanoma, don't forget you can get melanoma where the sun does not shine. So you can get them on the bottoms of your feet, and the palms of your soles. So we need to be looking there. And of course, you can get the amelanotic melanoma, the one that has no pigment. And this is one of the scariest ones because they can look like pink bumps or skin-colored bumps. And I'll show you kind of the methods that we use to really teach patients what to look for, because you can see already there's a range of what it can look like. Other sites to remember, you can get ocular melanoma, you can get melanoma of your nail bed, so, and mucosal areas as well. So we definitely also tell people to get their eyes examined, and I tell my female patients to mention melanoma screening during their gynecologic exams as well, and I always look inside the mouth. So how do we diagnose melanoma? Well, even in this day and age of 2015, our best tool is really still our eyes. We have this mnemonic, the ABCDE rule, which you might have heard of. A for asymmetry, B for border irregularity, color variation, D for diameter, changing in size, and E for evolution. And you can see this is the picture over here of the ABCDs that most people will find in textbooks. Most people remember those pictures. But above and beyond the ABCD rule, I definitely encourage all of our patients. Oh yeah, there's an F for funny looking. But someone decided to be cute with that. But there is one rule that sounds cute, but it's very, very important and very helpful. It's called the ugly duckling rule. And it's really meant to catch all those other variants that don't look like that big irregular spot that you see in the textbooks, the ones that might be small, the ones that might be symmetric, one-colored, pink, or skin-colored. And it's just anything on the skin that looks different from their other spots on their skin or just stands out, especially if it's growing or changing rapidly in size, shape, or color. I tell all my patients that if you see anything like that in your clinics, please don't hesitate just to refer. Better that it ends up being something benign than it being an undiagnosed melanoma. Sometimes we're lucky in dermatology. We actually see actual signs of melanoma. This was one of my patients whose wife actually wrote on him to give me a little note. This one's coloring looks like the melanoma one. So that was very helpful to me. Obviously, she didn't think her husband would remember to tell me, so she wrote it on him. So sometimes we're lucky. We get some real signs. But otherwise, if you use those rules, sometimes melanoma detection can be straightforward. You can see this one is the one that stands out, right? It looks like that ugly duckling, and it does look like more that textbook superficial spreading type, irregular, variegated lesion. But this is a typical patient I see in my clinic, and can you find the melanoma on this patient? It's harder, right? And I'll show you some of the tools that I use, but the pen mark helps right here, but this one ended up being the melanoma. But you could see with my handheld lens, it's called the Dermoscopy that I use, and I'll show you pictures of that. I could see that the actual kind of microscopic pigmentation was quite irregular and followed very unusual features, and this was a very thin diagnosed melanoma, 0.56 millimeter thick. And unlike the last patient, this is another one of my higher risk patients who already had melanoma who came in one day, and there was just a lesion that looked a little different. And I'm wondering if you can spot it. The pen helps, but here you can see there is a pink spot that wasn't there before, and it just, this is a patient who makes no moles, and we looked at this pink bump, and it was not acne, it wasn't a bug bite, we couldn't make any sense out of it, and this lesion ended up being an invasive melanoma, 1.2 millimeter thick, so it can be that subtle. So what are the tools we use to diagnose melanoma? Well, currently in our practices, most of us really are using dermoscopy, and I'll show you how that works. I also use total body digital photography or mole mapping to really help my patients who are more complicated phenotypically, that they have a lot going on. And it's impossible for anyone to memorize their own moles, and it's possible for any physician to memorize all of their patients' moles, right? So that's very, very helpful. And below the red line is kind of what's coming up in the future and what we're researching now to try to understand how new tools can help us diagnose melanoma even earlier and better for all of our patients. So let's start with dermoscopy, which is also called epiluminescence microscopy. So we know from studies that people who study melanoma and dermatologists are pretty good at diagnosing melanoma. By clinical exam alone, dermatologists are thought to be about 65 to 80% accurate when they diagnose a melanoma. Not perfect, but on their own, 65 to 80% sensitivity. With dermoscopy, with this tool and proper training, this goes up to 70 to 95%. So that, of course, is great and enhances it. And the one caveat before you all go out and run and buy this is that training is necessary. There has been a study that showed people who were not trained, residents who were not trained in their use of this, and they were actually worse at diagnosing melanoma than their naked eye alone. So training is absolutely necessary, and at this day and age, every dermatology resident in the country is getting trained in dermoscopy, and most people are using it now. In Europe, everyone is using it. But you can see for this example of a patient of mine who had a pretty small mole on their leg, when you look at it with this lens, which actually polarizes the light. So the light, when you look at the lesion, instead of the light reflecting back at you and giving you glare, you can see into the skin, and you can see the melanocyte structures that are being formed. And you can see kind of here, well, hopefully you can see that's irregular there, and that caused me to be a little more concerned about this very small lesion that was maybe about 3 or 4 millimeters big. And also in our total body, in our Beth Israel Pigmented Lesion Clinic, as I said, we do mole mapping, and there are several sites in the country that do this. And it's literally just, we have a professional photographer that takes standard poses for our patients, their entire body surface area. And when the patient comes to our clinic, we evaluate them and compare their baseline photos to detect subtle changes. We can also pick up new lesions, and we detect melanoma at earlier phases because of that. It also helps with patient anxiety. You know, if I don't know if you've ever met patients who are extremely anxious about getting melanoma, maybe there's a family history of it, maybe they're also covered with hundreds of moles. That's a typical patient that's very anxious, and they end up coming every month to see you, and maybe hooking them up into a clinic that has mole mapping would be something to consider. It definitely reduces the number of lesions excised. I have patients who come to me having had 60 moles already biopsied, and they were all fine, but for whatever reason, they were anxious, or their physician was anxious, and they just kept removing 4 or 5 every visit. You can imagine how much time that took for that patient, how much morbidity and cost that is. That's, again, not the goal of treating patients with moles, but we want to be more careful about observing them. So that's kind of what we are doing right now in the clinic, but let's talk about some future technologies that are up the pike to update you. So first I'm going to talk about non-invasive diagnostic technologies. So what if there were a device that we could use in the clinic that would tell us more about a lesion we were looking at, if it was worrisome for melanoma or not? So you might have heard of this device called MelaFind, and it involves multispectral imaging. And basically, this is a handheld device that you identify a lesion that you're somewhat concerned about, you take a picture of it, and it's going to beep and in a few seconds give you this answer. So how does that work? Basically, with multispectral imaging, this machine shines different wavelengths of light onto the lesion that you're suspicious about in the visible range, 400 to 1,000 nanometers. So blue light, purple light going into the reds, and it takes pictures of every single wavelength that it's doing. And you can see by the distribution of whatever's in that lesion, the distribution of melanin, blood, collagen, what's being absorbed by that light is going to be different per lesion, right? So they're taking pictures of every single wavelength, seeing how the absorption changes, and basically analyzing that information. So MelaFind then takes all of those images, they analyze them, they extract information from it, and then they compare, based on their computer brain, their data bank of what they've already identified with this device as melanoma versus benign lesions, and they compare their new image to their data bank to see where it lines up, if it's benign or malignant. And it gives you a binary output. It tells you either that it's okay, you can follow it, not worrisome, or it tells you it is concerning, you would want to consider a biopsy. So that's all it's telling you. So the clinician then has to decide what they're going to do. So this was the pivotal study that came forward for MelaFind in 2011, and basically they evaluated over 1,600 lesions, 127 of which were melanoma, and then MelaFind actually was able to detect 125 out of 127 of the melanoma, so it was a 98.4% sensitivity. However, the specificity was on the low side. It was 9%. So that was one issue that came up with this device. In that if you have 100 lesions, if you call them all melanoma, you're going to be great at detecting melanoma. But if 99 actually were not melanoma, you got it wrong 99% of the time, right? So that's some tweaking that's certainly being discussed right now. But from this study came right before the FDA approval of this, which was kind of a very split vote. I don't know if you followed that on the news, but it was approved for use by dermatologists. And so right now, the real-world application is being researched. How are dermatologists going to be using this? A machine that can detect melanoma very well, but may not be as good at basically determining that something is benign, right? Some limitations also include the fact that there's a certain size limitation. If the lesion is small, it might not be able to capture that image. It doesn't take lesions that don't have any pigment, so if you have a pink lesion, you can't scan it. So there are some limitations right now, but stay tuned. I think future research is in the works. The next technology is called reflectance confocal microscopy, or we call it confocal microscopy for short. And this is also a non-invasive imaging system, and you can see this is the actual device right here. And it's a real-time image also at the bedside. You can imagine someone wheeling this into the patient, putting this scope onto their skin and looking at a lesion in real time while the patient's sitting there if you're concerned about a lesion, so it's instantaneous. So how does this work? Well, it focuses a low-power laser beam onto a specific point in the skin, and then it detects the backscattered light from that focal point in a pinhole-sized spatial filter. And so it basically captures that image based on the different refractile indices of the tissue that it's shining into. So if you're shining into a pigmented lesion, you know how much melanin that had, how much keratin it had, the mitochondria, the organelles, the nuclei, the collagen, all of that's going to play a role in what that kind of back-filtered image you're going to get. So it helps the device actually determine what it's looking at. And like a microscope, you can actually dial this up and down on the skin. So this is real time. You're looking at a computer screen while you're dialing up and down. So it's kind of an in vivo microscope in horizontal planes down the skin. And it can go all the way down to 300 microns in depth. And there's a video monitor, and you have to actually look while you're scrolling up and down at what you're looking at. So these are some normal skin pictures. This would be an example of something very superficial in the skin. The cells, you're looking straight onto them. And as you went downwards, you go down to the lower level of the skin, the basal cell layer. And these are the DPs, the dermal papillae, which is the start of the next layer of skin. So you can see if you scroll up and down, you'd be looking at these cells literally like a microscope and a pathologist. And basically, studies have shown that there are certain characteristic features of benign mole cells. So if you learn that, you can identify that. The benign mole cells, basically the cells look round and oval and bright. They look monomorphic. Whereas the dysplastic cells, or the atypical mole patients, they would have slightly irregular, as you can imagine, but bright cells. They might be larger. Their nuclei might be darker, more variation to their size. And then, of course, the real kind of hitter here is what the melanoma cells would look like. And so studies have shown that these cells might be bright, they might be polymorphous, stellate, nest poorly defined, and the person reading this would be looking at these different features under the microscope to see if they're looking at indeed a melanoma. So I will say that the one kind of limitation of this is that you have to know what you're looking at, right? I mean, so you have to be trained to use this. It wouldn't be so easy just to pick it up and start scrolling on your skin to say, okay, oh, that's definitely a melanoma, that's not a melanoma. So you need to be trained, and short of being trained, there are models of this device taking pictures and then beaming it over to some experts someplace else in the country who will read your images, and then they give you the answer back whether or not they think that the lesion is melanoma or not. But that is a delay in diagnosis. So, but studies have looked at the diagnostic accuracy of confocal microscopy in the skin, and pretty decent sensitivity, 88 to 92%, specificity, 69 to 98%, and these are all through retrospective studies, and so certainly there is promise in this. And I will say that although this is used mainly in research settings, it has been quite useful for delineating borders of surgical excisions of certain lesions. There are some melanomas that seem to trickle and trickle and trickle and trickle out in the skin. And so rather than just cutting and then getting a positive margin and having to cut again, there are certain applications in tricky melanomas where they'll start using this to actually draw out the border of where the melanoma cells end, so the surgeon has an easier time actually removing it. And this study here actually showed that confocal microscopy was similar to dermoscopy, and maybe both could be used together to really help the clinician better identify melanoma. So in short, with confocal microscopy, more training is needed for bedside diagnosis, or you can send your images to an expert consultant and have them beam back the answer to you. Certainly there's question about automation in the future. Maybe the machine could just tell you right off the bat based on some computer algorithm if the lesion is concerning or not. So that's all coming up. And the last non-invasive kind of device I'm going to talk about is electrical impedance spectroscopy. And this is using actually energy, electrical energy, to assess the skin. Again, and this is all before taking it out, before biopsying it, to help the clinician determine if this is a worrisome lesion or not. So this device measures the overall resistance of the skin in 35 different frequencies in different depths to see how the normal skin adjacent to the lesion is different from the lesion in question. So there's a comparison. And of course, again, the cellular makeup of the lesion is going to impact what that what that read is going to be based on your cell volumes, plasma membranes, and how that cell is conducting. And the lesions get a score, and then based on the score, the clinician will then know if it's a concerning lesion or not. And so the studies have been done, and this particular study showed that this device was accurate and safe to support clinician sensitivity being about 97%, specificity being 34%. So definitely something to watch for in the future. So now we've talked about light to help us diagnose. We've talked about electrical energy to help us diagnose melanomas. What if we took genetic information? So gene expression profiling is also on the forefront of and kind of up and coming in terms of melanoma diagnosis. So just basically to give you the preview, gene expression profiling would involve taking some of the tumor tissue, extracting the genetic material from it, and then amplifying kind of what signature patterns you're looking for in that tumor sample to see kind of what that pattern would eventually show. And in the two examples I'm going to show you, basically with these signature patterns, they then are able to determine if your lesion is concerning or not. So the first example of this is epidermal genetic information retrieval. And this basically, this is a technology by DermTech where someone determined that they could put an adhesive patch on the lesion you're worried about and actually take off cells from the top of the lesion and extract the RNA from it to determine whether or not there are genetic mutations in there that match their melanoma sequences. So this is definitely something that would be desirable for the patients because it's very non-invasive. And imagine if they could avoid a biopsy, they could just have a piece of tape on them, rip it off to have this done. And so a study was done to look at this in the clinical setting, and it showed that this lesion in the cohort that was studied had 100% sensitivity, 88% specificity. So that's definitely being researched right now. And then, and this other gene expression profiling tool that we have that's actually commercially available now is called Decision Diagnosis Melanoma Test by Castle Biosciences, and they use this technology to determine actually if a melanoma has metastatic potential or not. So that's kind of a different application of this. So this first came out, and I remember hearing about this from NBC News Tonight or something because it was one of those news flashes for uveal melanoma because it's such a rare disease, and there were no good tests before to determine which were the bad melanomas that metastasized and which were the ones that actually did okay. And so that was the first market for this tool in uveal melanoma to determine which were the risky metastatic, more likely to be metastatic melanomas, and which were the lower risks. So they classified them as class 1 versus class 2 based on, again, the genetic mutations they found in the tumor tissue. Now, they have now branched into cutaneous melanoma to see if they can do the same thing. And the studies have just come out recently looking at how this test did versus real life in terms of sentinel node biopsy. And then they showed that in this study, the positive predictive value was of the gene expression profiling was 50% compared to, again, in their cohort, a 55% positive predictive value for the sentinel node biopsy. And the negative predictive value was 82% versus 76% for sentinel node. So this is definitely something that's also being studied because, as we'll probably hear about later, with a sentinel node biopsy, there are some patients who have a negative sentinel node biopsy, but they do end up going on to have metastatic disease. So there are some patients that somehow they don't spread that pathway. This test argues that perhaps if we test those patients who had a node that was negative to double check that they really didn't have a metastatic potential, perhaps we could catch and kind of treat those patients at an earlier time. So that's kind of the application they're going for. And so we're in dermatology trying to figure out how would we use this in our clinical practice. And so there's discussion of would we use it on all of our thinner melanomas that actually don't get sentinel node biopsies, the less than 1 millimeter thick ones, for example, with no high-risk features, to see if that would change our management or how we would approach if someone had this test that said they were potentially at more risk for metastasis. And then certainly those who were greater than 1 millimeter but had a negative sentinel node. And then lastly, I should say, there's one other kind of test out there called Myriad, which you might have also heard of, which very similarly has this genetic expression profiling. But this test is more trying to go after if you have some difficult tumor, you're trying to figure out is it melanoma or not. They say, okay, if you order this test can help you determine is it melanoma or is it just a benign lesion? Because there are all sorts of borderline lesions that pathologists will argue day and night about, is this melanoma, is it not? Because again, they're looking at stains and they're looking under a microscope, but this would be testing the genes. So again, this is all coming out in the forefront, and sensitivity that was published in ASCO for this test was 90% in being able to accurately identify the melanoma, the gold standard being a dermatopathologist review of kind of what the diagnosis was, 91% specificity. So with all these tests, we're still trying to figure out how are we going to use these, but certainly we're very encouraged by their development. So in summary, you can see all the different technologies we talked about for melanoma diagnoses. Keep in mind, with sensitivity and specificity, they're kind of apples and oranges because all the different study designs were different for all these different tests. But you can see we're making progress. This is really important technology, something we need to embrace in terms of advancing the field of melanoma. Because again, if we can detect and identify melanoma earlier, people are going to survive better. So that's our goal. So in summary, we talked about melanoma screening. We talked about how research is really underway examining the benefits of population-wide screening, and stay tuned. Hopefully there will be more guidelines in terms of who really needs to be screened and more people really sent for screening. And a personal goal of kind of my research is to really better understand risk factors, to better target populations that really need the screening. Perhaps those are the populations that are at risk for more advanced disease. For melanoma diagnosis, we talked about the new technologies that are out there, and we're making progress. And the goal really is to support clinical decision-making. We certainly need larger studies, more prospective blinded studies, reproducibility of study results. Whatever device comes to the bedside has to be easy to learn and user-friendly. And I did want to mention that none of us really predict in the future that these devices are going to take over the human in the room, the clinician. These are really meant to be adjuncts to the clinical exam. So there's really no substitute for the clinician in the room. And even when it comes to moles, pigmented lesions need to be evaluated in the context of the patient. We touch, we feel, we look at the patient. It's a global evaluation that we make. So certainly in no time in the future do I think that these devices will replace any clinician in the room. So I'd like to thank all of my colleagues in our melanoma program at Beth Israel, who I learn from every day, and I want to thank you for all your attention. Thank you very much.
That was a fantastic update, and I learned quite a bit from it, and especially some of the newer optical devices that we hear in the news that they're touted as the be-all, end-all, and to see that their specificity is around 9% is really eye-opening. So we'll open up the floor to questions. If you have any questions, we have microphones on the front of both aisles.
We actually have the derma scan. We're from Kettering Health Network out there, and we do the sun damage. And we go into the community and we use the A, B, C, D, and E. And I know for myself, when you spoke of many melanomas being round and being pink, and do you know how soon they're going to be adding the ugly duckling? I think that's an excellent, because many people will say, none of mine match this, I'm fine. I was just wondering, do you know how soon that information is going to be added on so we can communicate that to the public?
Yeah, so that's a great point, and I'm hoping very soon. I think that the ABCDs keep on growing, as you can see, to the E and F, but I think that E was added for evolving, which was hopefully meant to kind of cover even the pink lesions, but we're all talking till we're blue in the face, trying to really make sure that everybody hears that message, that melanomas can be pink, they can be skin colored, they don't always look like the textbooks, and everybody really needs to know that, and hopefully anybody here who's in primary care can share that with their patients, because that message still needs to get out there, and those are the ones that usually are detected late, and they usually have a worser prognosis because of that, so, but hopefully soon.
Thank you.
Thank you.
Thank you again.